the impact of the second wave of COVID-19 infections on the new academic year, they've now delayed the opening of both private and public schools. Another 2-week delay then for South African school children.
School management teams, SMTs, shall report for duty on Monday, the 25th of January 2021. Teachers shall follow on Monday, the 1st of February. And lastly, learners will return on Monday, the 15th of February.
What we are seeing and we're concerned with is the extent to which there is complacency or a sense of fatigue in the community. We see that these are feeding into the super spreader events.
The metro is in serious trouble. Our cases are increasing daily.
The situation is so dire that the paramedics have to wait for 20 hours to get attention.
Very, very, very bad. We wait 6, 7, 8, 9 hours a day waiting for beds inside hospitals.
Health Talk is your go-to information hub for all things relating to your health. The show covers South African and international health stories ranging from personal health to policy and analysis. Viewers can also interact with our studio experts via phone-ins, Facebook, Twitter and voice notes. Be sure to tune in to Health Talk Saturdays between 9 and 10 a.m.
As the good news of last week's arrival of the Oxford AstraZeneca vaccine diminishes because it fails to prevent mild to moderate infection of South Africa's 501Y.V2 strain of COVID-19, another, the Johnson Johnson Ad26 Janssen, shows some positive news with the local variant. President of the South African Medical Research Council, Professor Glenda Gray, who was part of the ENSEMBLE Study Team testing the Johnson Johnson Ad26, which took place in South Africa, the US and Latin America, joins us now to tell us a little bit more about this. Good to have you. Thanks, Prof. Thanks very much for being with us.
Good morning.
So, last night, not great news being delivered. Obviously, as we kept on hearing, there was some good news and some bad news. So let's get the bad news out of the way, because I think a lot of people were really pinning their hopes on the arrival of the AstraZeneca vaccine into South Africa. Now we get the news that this just does not seem to be the right vaccine for the strain that we're currently seeing in South Africa. Talk to us about this. What is going on with the major concerns around the Oxford AstraZeneca vaccine?
Sure, thank you very much. So we had a very stable virus in the beginning part of the epidemic, and it didn't mutate a lot. And towards the end of the year, in October, around the world, we started to see the virus mutate. And we started to see the current wild-type virus be replaced by this mutant variant that you've spoken about, the 501YV2, that became the predominant virus circulating in South Africa. And when we had evaluated the AstraZeneca study, a vaccine in South Africa before the variant, this vaccine showed efficacy. But after the variant started to circulate, there was diminishing impact on the virus. And eventually, when we looked at the data at the end, in February, we could see that this vaccine was not impacting on virus at all. And so you can't forward or advance a vaccine to healthcare workers that doesn't work. So we're in a situation where it would be untenable to vaccinate healthcare workers with a vaccine that you have very little probability of working. We have no evidence yet that it works in severe disease, but if it doesn't even work in mild to moderate, it would be irresponsible to roll out a program, and particularly because our healthcare workers have been so hard hit by the COVID-19 diseases. They're having to treat patients without proper PPE. They've seen their colleagues die. They've seen their colleagues go to hospital. So we can't roll out a vaccine that doesn't work. It would be untenable for our healthcare workers.
Yeah, it certainly would be, and that is something I think we're all acknowledging is the fact that there is no way we could give these to the frontline workers who are seeing this new strain all the time, and this is it does not make any sense to roll out this particular vaccine. Let's try and understand, and perhaps maybe you aren't the right person to speak to as to why we as South Africa decided it was a good idea to secure 1 million doses. I know that we are going to be joined by Anban Pillay in the next hour. Maybe he can answer that question. But perhaps you understand as well. I mean, we are taking advice from the scientists. You are a scientist that is involved in, some of the decision-making processes. Why did we go for the Oxford AstraZeneca in the first place when the new variant was already discovered in November? And then we bring this into the country. Surely there were already some early results showing that this was not going to be the effective or the right vaccine for us.
At that stage, there was no knowledge that this would have an impact. And as the data started to accumulate, we were furiously looking at the impact of this virus on neutralization, and studies were being undertaken day and night in South Africa, in fact, to try and evaluate the impact of this vaccine on the virus. And we only knew in the last few days that, in fact, what we were seeing in the laboratory may have an impact in the body, as people were exposed to the virus who had got the vaccine. So this is something that we didn't know. And we could not have predicted. We've seen at a global level the difference in vaccine efficacy between South Africa and the UK or in Europe. For instance, the AstraZeneca vaccine works very well in Europe and doesn't work in South Africa. The Novavax vaccine has seemed to work quite well in the UK, and we take a hit in South Africa because of our variant. And similarly, the Johnson Johnson, although a very good result, did take a hit in terms of vaccine efficacy. So these data emerged literally in the last 10 days, and by that stage the vaccine was on its way. So I don't think that we can't predict the virus, and the science must lead. What would be worse is if we didn't know this and we hadn't done experiments, and we would have rolled out a vaccine at great cost to healthcare workers that had no impact. And so I think the fact that we know this now means that we can act. We could always, there are lots of things we could maybe do with that. We could do other studies to try and understand whether AstraZeneca has a place or has a role in our country. We need to do that research. We could think about replacing or swapping out the doses. We could speak to COVAX to see whether there was a way of negotiating with them about the vaccine. So I think there are a lot of things we could do. We could try and find a use for the vaccine in South Africa, and I think people will be pursuing all these options. There may be we might be able to do prime boost studies to increase, augment the immune responses, and so all of those kind of research will be underway. So I don't think it's what would have been a waste of money would have been to roll out a vaccine that didn't work.
Yeah. Now, obviously, one of the things we heard being spoken about last night during the online briefing was that the possibility that the Oxford AstraZeneca vaccine can still be used, but used in conjunction with a booster vaccine. Have we been in contact with AstraZeneca with regard to something like this? I mean, are they working on a booster vaccine? Are they working on modifying their vaccine to try and work against this strain that we have found here, the 501Y.V2 strain?
Yes, so they are looking at adapting the vaccine to the strains in the new variants that are emerging at a global level. And there are talks about trying to combine it with other vaccines in a way to boost the durability of the immune response and the variability of the immune response. And so all these talks are underway, and I guess this kind of research will take place this year. As we speak, most pharmaceutical companies are looking at how to replace the current wild-type strain that was in our first generation of vaccines to adapt to the variants that we're seeing at a global level. So this is going to become a global problem. And South Africa has fully understood now how much of a global problem it is. And maybe in some ways we are fortunate because we have the evidence about the vaccine, whereas many other countries actually don't know what the impact of the vaccine efficacies will be on their variants. And so we are, in a way, fortunate because we have some evidence to help lead or inform our rollout strategy.
It's quite interesting because we do see, as I think you mentioned a bit earlier, the UK are using the AstraZeneca vaccine. This is one of theirs, and I wonder, and perhaps maybe you can also understand, because they have their own variant. I mean, there are variants and strains all over the world, different ones. I mean, we're not unique in South Africa to have a different strain or variant of the coronavirus. But from studies, the AstraZeneca vaccine, does it have efficacy against the strain in the UK? Because we do know that they are using this one.
So it appears to have efficacy, and data there has demonstrated that. But it's very important to continue to monitor it and to see over time what's happening. So what you have to do is you have to make sure that when people get vaccinated and they do get the infection, because remember it protects against mild and moderate, and the data on severe is still outstanding, is to make sure that every person that gets COVID-19 has received the vaccination has their virus sequence, so we can see what impact or pressure the vaccine has put on the virus and how it's trying to escape the immune response that the vaccine has induced. So it's critical as we roll out all of these vaccines in all parts of the world is that we look and evaluate all the time the impact that the vaccine is having on the virus and how the virus is trying to find ways to escape from the immune response.
And I suppose that's the risk that comes about where we work on a vaccine in such a frantically fast amount of time. And we understand this, that it is mutating, it is changing, but there is this rush to get a vaccine while the virus is mutating. And this is something that we need to understand. I mean, we all have to become scientists overnight. I'm realizing this as the days and minutes tick by. The one concern, and rightly so, is that this is a lot of money we're talking about that we've invested into these vaccines. And now there's this other issue that was thrown our way, is that when it arrived in the country, we found that they are going to expire in April. And I know that there are a lot of other tests. I'm still talking about AstraZeneca. I know that there are tests and things that we're still going to perhaps do, but we need to put them on ice for now, so to speak. But with them expiring in April, I mean, that must put a lot of pressure on us. And where to from here?
So for vaccines, you usually do potency assays, and you do them from time to time. And so what happens is that you have a lot that stays at the manufacturers. And when the shelf life of a vaccine starts to expire, these potency assays are redone to evaluate whether the vaccine still is potent. And so this is normal practice. So what will happen is when you reach almost expiry date, the experiments are done, and you then evaluate whether the seed lot is still potent. And then if it is potent, you then reissue the registration for the new expiry date. So this is common practice at a global level because you don't know when your vaccine is going to expire, and the experiment that you do gives you a certain time frame, and then you have to reevaluate it. You do what we call a certificate of analysis that reconfirms that the vaccine is still potent. And so it may not have been evident at the beginning, but very quickly people do experiments to make sure that the vaccine is still potent and has not expired. So those are technical things that may not be obvious to everybody, but your certificate of analysis will be redone to ensure that the vaccine is still potent and viable.
All right. We'll speak a little bit more to Anbin Pillay about that. He's joining us in the next hour on the program. But while I've got you, what I want to now talk about is the Johnson Johnson AD26 Janssen vaccine, because that is what you really focused on last night. The talk now is that this could be the direction that we go in because the efficacy has been found to be much higher. And there's even talk that this is what's going to be given to our frontline workers, even if it's part of the trials, the ongoing trials that Johnson Johnson are conducting here in South Africa. Give us an understanding. Obviously, this is a big disappointment to the healthcare workers about AstraZeneca, but let's start giving hope again. how fast is this going to happen? What is the way forward with Johnson & Johnson? And is this now the preferred vaccine for use in the country?
So we have beautiful data on the how well Ad26 vaccine works in South Africa. The vaccine trial was executed at the time of the second wave, and where the new variant was circulating. So we know exactly how this vaccine fared, and so that's very fortunate for us. The good thing about the Ad26 vaccine is it's a single shot. You give it once, and you have durability. There are other studies ongoing to see the utility of a second shot of the vaccine in case you have to do a boost. But this single shot vaccine, so it's easy to administer. It has a refrigeration of 2 to 8 degrees. You can use a fridge and a very little cold chain monitoring. Once you've taken out the fridge and you're preparing it, it has a 4-hour. You must use it in 4 hours, so it gives you a lot of time to work with. And you don't have to come back for a second dose. So that's an important thing. And the single shot vaccine has been, irrespective of what region you are in the world, it has protected against hospitalization and death. So yes, maybe this vaccine may not stop you getting the sniffles, but this vaccine will stop you from dying or from going to hospital. And I think that's a very good and powerful vaccine because that's going to help us keep our hospitals open, and it's going to protect our healthcare workers.
So, as you say, single dose, it's a realistic storage capacity and temperature that we can actually attain here in South Africa, whereas, I mean, Pfizer minus 70 is a tall order in that cold chain. Let's talk about the fact that have we already ordered some of the doses for this drug? When can we expect them in the country? Is this now the route that we are going to go in terms of vaccinating our frontline workers, Johnson & Johnson, and when?
So I think there'll be many vaccines brought into the country that we know work against our variant. And we can expect, like other countries, not just having one vaccine that's there. Like the US, like the UK, they have Pfizer, they have AstraZeneca, and in the US they also have the Moderna. And so we can expect a lot of different vaccines. So for us, the first vaccine that we hope to introduce into the country is the Ad26 and to healthcare workers. And because we're in this phase between hearing the results of the trial and getting the vaccine registered, you're in a kind of regulatory no man's land. And so although we know the vaccine works, it's still be waiting to register. So one could always just wait for the vaccine to be registered, but that would be 12 weeks away. And that's already been submitted to the FDA, and the FDA will make a reading on it towards the end of February. It then goes to the EMA and to WHO, and at the same time it comes to South Africa. So if we wait for the regulatory processes to occur when you know a vaccine works, then you have to ask yourself two questions. Should we wait the 12 weeks to get the vaccine, or should we use the vaccine because we know it works under what we would call regulatory or clinical trial conditions, which means it's what we would call a phase 3, a phase 3B study, which means we know the study works, and the 3B is how do you roll it out, how do you execute the rollout program. So it's much more about learning about how you roll it out rather than learning about whether it works or not.
Just two very quick questions before we go. I mean, the issue of healthcare workers being guinea pigs, and you have specifically and said this, that healthcare workers will not be guinea pigs. However, you know, this is unfortunately the reality when you are in, front of line to actually get the vaccine. And perhaps the AstraZeneca was stopped just in the nick of time. This could have been administered without us even knowing that this wasn't good against this particular variant. So obviously time is what we need on our side, but we don't have it on our side. So let's talk about the where we put healthcare workers in all of this and using it on them.
So healthcare workers are not guinea pigs at all. This is an active vaccine, and we know we're not giving them a placebo. So they're getting an open label vaccine which we know what's in it. And we're administering it under these conditions because there is a regulatory time zone that makes us operate in this way. So the healthcare worker would get the Ad26 vaccine in 12 weeks' time when it's registered. However, under these conditions, we can give the vaccine much more rapidly. And so what we are doing is that we're accelerating the timeline to give vaccines to healthcare workers because they need it before the next wave comes. This vaccine will protect them from dying and protect them from being hospitalized. I can't see how being protected from death and hospitalization is making you a guinea pig.
Just again, as I said, this is the final question I'll ask you. Let's get an understanding about this actual vaccine that's being worked on, no matter which company or how it works. I mean, a vaccine is something, and if you look at the definition of a vaccine, it's something that actually makes you immune to the thing that you're having it administered to you for instance, COVID. So let's now talk about this. Will having the vaccine make us immune to COVID? Will we never get it again? Is it something that it'll put into our bodies that will build up whatever it is to stop us from getting COVID again? Or not necessarily? I mean, you know, there's been a lot of talk that this vaccine is actually just being sold as a vaccine, but it isn't necessarily a vaccine. There is another definition for this. Perhaps you can put some clarity on this. I mean, you're a vaccinologist. This is what you've studied. So help us understand what it means by having a vaccine, particularly in this day and age.
A vaccine is a tool that teaches your immune system to make an immune response that once you come in contact with the pathogen, in this case a virus, your human immune system mounts a response to neutralize or inactivate the virus. And so that is how vaccines work. And the vaccines were made against the wild type coronavirus, and these vaccines worked against the wild type coronavirus. So over time, as viruses evolve, they learn to escape the immune system. And so the vaccines that you made in the beginning may not be the same, may not help you as much as the vaccines to the identical strain or variant that is circulating in your country. So over time, we do need to replace our vaccines to make sure that we are keeping up to date with how the virus is evolving. And so that is how we have to chase the virus. Vaccines have lots of benefits. They have the individual health benefit. So by taking a vaccine, it can stop you from dying or going to hospital or getting sick. So that's an individual health benefit, which is a very good. I would take a vaccine if it protected me from dying or from going to hospital. A vaccine also has public health benefits in that if you give people the vaccine, we will stop people from going to hospital and dying. And that means that we will relieve the health system and we won't have this devastation that we have in our country. And it also has a public health benefit, an economic benefit, because if we can get people back to work, schools open, teachers teaching, that means that we can get our lives together. But over time, we probably will have to have new, depending on how the virus evolves, we might have to have regular vaccines to the strain that's circulating, much like the common influenza, annual influenza vaccine that we get. And so we don't know. We're in a data-free zone. We can hypothesize about what's going to happen, but we can only understand as we go along the way the virus is evolving. And so at this moment in time, we can just predict, but we have to have evidence to see which way we're going. And so at a global level, we need to get vaccines out, because the quicker we get vaccines out, the quicker we can control the global transmission, and the quicker we can find ways to mitigate the emerging variants.
Yeah. A worrying statement I'm taking from you is that we're in a data-free zone, and I understand that. And I mean, I'm just seeing quite a few tweets coming in from healthcare workers and people saying that if they refuse to have this vaccine, and I haven't really been able to get a definitive answer from anybody, if a healthcare worker refuses to take this vaccine, are they well within their rights to do so?
So no one is required to take the vaccine, and if healthcare workers are refusing to take the vaccine, that's within their right. Hopefully they will see the evidence. Once this vaccine is registered in 12 weeks' time, they could still then take it. So if they don't want to take it now, there's always an opportunity for them to take it when it's registered in 12 weeks' time. it is most likely that this is the vaccine that will be rolled out because it's a single-shot vaccine and because we know this vaccine protects death and hospitalization. And so I guess if the healthcare workers want to wait and see what other options come down the pike, that is their prerogative.
Yeah.
However, we hope that the healthcare workers can see the data. I think the data speaks for itself. There's a lot of people in South Africa that I know, my researchers who are working on this vaccine have asked me, Glenda, can we be first in line? Can we take the vaccine? Can we get it? And so if the researchers who worked on the vaccine want to be the first to take it, that is evidence that there's huge trust by the scientific community to take the vaccine because they've seen what it did. We've seen the vaccine roll out. We see the impact on hospitalizations and death, and this makes us want to be first in line to take the vaccine. In fact, I want to be first in line to take the vaccine.
I was hoping you were going to say that. That I think will give a lot more people hope on this one. Prof, thanks for your time. Professor Glenda Gray talking to us about, firstly, concerns regarding Oxford AstraZeneca vaccine and, of course, now Johnson Johnson, which appears to be the preferred choice for South Africans. This, of course, leads us into our news. That is the top story. So, Sakina, I'm going to hand it over to you.